Dr. Gantsoudes, welcome to the Nailed It Ortho podcast. Again, thanks so much for coming on and being a guest. We're looking forward to this talk. So, welcome to Nailed It Ortho.
Thank you for having me. Appreciate it. Happy to be here.
Yeah, and I myself, for people that are listening, I'm Cole. I'm one of the hosts, and I know we have my little brother Jay on here somewhere.
Whatever. I'm the guy who keeps this show running. We're actually about 30 minutes late because of Dr. Cole right now. So
here we go.
Things y'all guys don't know about.
There's a bus. I'm always just thrown under the bus every time. It's how it goes. So. Well, Dr. Gantsoudes, we kind of like to start out the podcast asking just a couple of questions, getting to know you a little bit better.
Sure, of course.
And a fan favorite question that we typically ask is, if you had a piece of advice that you give to yourself now from when you started a residency, is there anything that you'd go back and tell yourself, regarding anything residency or just any type of advice?
You got this. That's it. It's just, you got this. Just persevere, survive, learn something from even, your mistakes, other people's mistakes. Just learn something every day. You pretty much only have 60 months to learn everything you're going to learn before it's your name on the bottom of the page. And just take advantage of that time. It is temporary. You will get through it.
I like that. That is actually something I have to tell myself every day. And so that's awesome. And I think
now I'll put the more petty side of me on there, which is I found someone a year or two ahead of me who I thought I was a better resident than. And I said, you know what, if that guy can make it, I totally got this.
Hey,
that's my more petty side.
Yeah,
that I had to persevere with
Jay, that's what they say about you, huh? Over there.
Whatever. Hey, whatever helps, man. I really do think it's important to think a little bit further ahead because, in my opinion, residency can kind of beat you down. You work pretty hard, and you're not getting a lot of good jobs and thank yous and things like that, and you're expected to perform at your peak every day, and you just have to kind of just keep trying to do your best and try to learn as much as you can. Like you say, it's only a 5-year process, hopefully, and take what you can.
Yeah, hopefully.
Hopefully.
For most of us.
Yes, absolutely. Take what you can and try your best to become a good surgeon if that's what you chose to do. So on to the next question. A lot of people who are interested in pediatrics, I hear, often believe that they have to go to pretty much, if they're interested in orthopedic pediatrics or pediatrics orthopedics, they feel that they have to go to like a major academic center. Do you think that's always the case?
I don't think so. I think it's definitely a choose your own adventure thing. Where I did my residency, we had very little exposure to pediatric orthopedic trauma. And so when it came down to my final two choices of where I really wanted to go, I would have been happy at either of the two places. But if I was going to be joining a place that had level 1 trauma call, I don't feel like one would have prepared me as well as the other one did. So I ended up choosing the one that had the bigger trauma exposure, but I think I would have been fine at either place. I don't think you have to go to one of the whatever preordained places. You want to go somewhere where you're going to get your hands dirty. I will tell you that one of the preordained places that I interviewed at, I would rather not have done a fellowship at, quite frankly. There was little operative opportunity for fellows. It was, told to me that it was the resident service. The fellows are there to observe. And I would have been like, no, thanks.
Oh, wow.
This isn't a watching career. This is a doing career. I need to do. So, I mean, I think we're all smart people. There are no dummies in ortho. It may feel like that someday, but there really aren't any dummies in ortho. And I think we know ourselves pretty well for the most part. And, you just got to trust your gut. Your gut got you this far. So.
Very true.
Yeah.
Those are all good words and good advice. This is actually right around times. I know a lot of people are just getting their fellowship interviews today. I know, and then around this area. So there may be some residents listening to this. So definitely take that into advice or into consideration.
Yeah, there's no one place. I mean, it really bothers me. It's like if someone says they don't get into Harvard, their life's over. It's like, man, that's totally not true.
Yeah.
The biggest advice I give to people now who come to rotate is like, go get educated as cheaply as you can. That's my advice to you.
I like that.
Sure.
That's a good one. And kind of still just rolling off of what we were just talking about. What, like our last question is, what brought you to choose pediatrics of all the different fields?
I went to med school wanting to be a pediatrician, and then I did my peds rotation at a very small hospital that had in the peak rotavirus season. And so I hated my rotation. And I realized I liked to do procedures, got switched on to orthopedics. And once I got into ortho, I did the typical roulette of trying every single subspecialty there is. And we eventually found my way back to peds ortho.
Perfect. That is like a great circle around. Great story. Well, let's get into the topic of the day, which is we're gonna talk
Yeah.
a little bit about some clubfoot. And I know you gave talk a little bit earlier today, so hopefully we get to round two here. And hopefully we cover some high yield things and cover some things that if there's some attendings listening onto this, that hopefully that they can kind of use in their
Uh-oh.
practice. So kind of start out with just a general case, because this is how they may present. And say, for example, you're doing clinic and you are referred a newborn who the pediatrician thinks they have clubfoot, and that's all you have to go by. What are some of the things that we look for when we're talking about, we're taking a history and we're examining these kids, and then I think after that we can kind of get into what clubfoot is.
Sure. So, I mean, I will tell you the biggest mistake I made when I first started out my career was when someone referred a patient to me as a clubfoot, I believed them. And so a couple of times I caught myself going through the 15-minute spiel to a family, and then I would uncover the baby and be like, oh, that's calcaneal valgus foot. That's not even clubfoot. Forget everything I just said. Your kid's fine. Go away.
Yeah.
For me, my first thing is kind of trust but verify. So my first thing when a baby is sent to me, I eyeball the baby. I don't believe them when they say it's clubfoot, because one of my most popular lectures I give regionally here is a lecture that's titled "It's Not All Clubfoot," where I teach them about the different foot deformities, what is clubfoot, what isn't clubfoot, and how to properly refer. So for me, the full musculoskeletal exam on a baby is 45 seconds or less. It really does not take a lot of time. And depending on what you're examining the baby for, you have to be very methodical in how you do it. For every newborn that I see, whether it's for clubfoot or anything else, I check the hips first, because that baby's got to be calm for the hip exam. So the baby stays in mom or dad's arms, fully bundled up until you are ready. And once you're ready, take the baby, put him on a nice surface. Mom and dad can be nearby, keeping him happy. Get the baby naked from the waist down, leave the diaper on to the last second, and then take the diaper off, do a quick hip exam, get your eyes at the hip level, make sure there's no difference in abduction at all. And then I put that diaper right back on. I don't want to get wet. And then I go down to the feet and make sure I got all 5 toes. And then I'll assess for the 4-foot deformities. The most common 4-foot deformities are metatarsus abductus, clubfoot, calcaneovalgus, and then finally vertical talus. I'll assess for all of those, make my way up to the knee. We already did the hips. I'll squeeze around in the belly, make sure nothing else going on around there. Up to the clavicles, make sure clavicles are present, do a quick torticollis check the fontanelles, roll the baby on their side, check the spine, look for sacral dimples, and then do a Moro, and I'm done. So that is my very quick physical exam. The history now, I can do it in reverse, because if I got a happy baby, I don't know how long I got the happy baby. So I'm just gonna take advantage and do that exam right away. I go and get the history. As far as history for clubfoot goes, there's nothing that matters. Either it is or it isn't, except for family history. But again, it doesn't matter. Clubfoot's binary for the most part. Either it is or it isn't. And then when you're talking about history, there are a couple of things that might show up on a test question where they say, which of the following is found to be related to risk for a future sibling for clubfoot? And family history is by far the most important. Maternal smoking is something that's on there. Everything else is kind of really small odds ratio, risk factors. So nothing really too much to talk about there. As far as limb length discrepancy and things like that go, there's really not a lot of data looking at clubfoot and acquired limb length differences, with the exception of those that come along with tibia and fibular hemimelias. Beyond that, it's very rare to have a clubfoot be the source of a limb length discrepancy. And for almost all these kids, their neurologic status is normal, grossly speaking. When you look microscopically, some of these kids have a diminutive vessel appearance, and they're going to be, you can have a 2-vessel foot, you can have a 1-vessel foot. That comes into play way later, where if you ever get a late referral, you always want, and you see scars on the foot, they've been previously treated, you want to be darn well sure that someone didn't turn a 3-vessel foot into a 2-vessel foot, or a 2-vessel foot into a 1-vessel foot.
Absolutely. Yeah, that's probably good to know before doing any kind of surgery. You got to know what that vascular status is like before getting too far. And I'm actually even glad that you just kind of briefly went through that musculoskeletal exam. I know earlier on in my residency, and I didn't even know that we got consults on babies, and all of a sudden I get a page, and it's a baby that was just born 12 hours ago, and they telling me to come and evaluate them. Something's going on with their knee. I'm like, well, where is he? First of all, I don't even know what floor he's on. But yeah, so that was like one of the things that I had to take some time out and start reading up, like, man, how to even do a full exam on a baby. So
they don't teach it to you in books.
Yeah,
I'll tell you that much. It's something you got to learn by doing, unfortunately.
Absolutely. But like you say, the babies, they either they're like not with it, or they can be kind of relaxed for you, and you might get them a little upset, but they're
get them while you got them.
Yeah, you got to just
I will tell you, that hip exam is such a subtle exam. I've watched people do like Ortolani and Barlow, where they're like lifting the baby off the table, and it is just a very subtle, but the Barlow and Ortolani, very subtle movements, and you lose it when you're kind of a little rough on the, when you get like ortho rough. This is not a Brutane exam. There's a time and place for Brutane, and it's not in the newborn nursery.
Yeah. And they're so small, you don't want to put all that force on them. They're so cute.
Exactly.
But so back to Clubfoot.
Sure.
And so we mentioned, just kind of when you was going through that summary, you actually mentioned some of the factors and family history and things like that to look out for. But can we just briefly talk about the etiology of Clubfoot?
So first and foremost, just to throw this out there, it is not a positional disease. It is a genetic disease. So, or genetic condition, I'll say. So it's not a packaging disorder, right? The packaging disorders are metatarsus adductus, hip dysplasia, and torticollis, when there's too tight of a space. For Clubfoot, there is a genetic etiology. Dr. Matt Dobbs and his wife had done a lot of research looking at specific genes and gene tests and things like that. To be honest, there's probably not a lot of applicability for those kind of things. This is one of those things where if you find out your kid's got clubfoot, you come see a pediatric orthopedist who talks you off the ledge for 25 minutes, and then, we'll go through the whole Ponsetti treatment. I do probably, 3 to 4 prenatals a month, where I'll have a very scared mom or dad come in and talk to me about, is their child going to be able to walk or play sports or dance? And, I say, yeah, look, not a problem. And every pediatric orthopedist has their 4 or 5 athletes or famous people who've had clubfoot they throw out at parents. And it really helps calm them down a little bit. But as far as other than family history and maternal smoking, I doubt there's anything that you guys will ever be tested on about it.
Yeah. Okay. I think that's good. And I think you even mentioned one of the things that I remember seeing a question on that I didn't even know was about the vessels, and I think an absent anterior tibial artery was associated with clubfoot. I had no idea. But yeah, that just to kind of reiterate and point that out.
So it's important to think of clubfoot as not just being a foot problem. The entire leg below the knee is altered, right? The calf is smaller. It's going to have an ultimate strength that's slightly less than the other side. And so if the tendons are malpositioned, if the ligaments are tight, it makes sense that there may be some kind of angiogenesis problem there too.
Right.
And I see you're bringing me to the next slide. This is very important in your assessment. So when you look at a baby's foot, how do you know it's clubfoot? You guys all know the mnemonic CAVE, and it's a very useful mnemonic, but perhaps none of those is more important than is Aquinas. You really don't have a true clubfoot that doesn't present, or that presents on day 1 without Aquinas. You have to have Aquinas. if you don't have Aquinas, you may be more of that like so-called positional clubfoot. But if it's not Aquinas, it's probably not clubfoot. It might be one of those like little positional metatarsus adductus that doesn't really have a varus component with it. And so when we talk about the CAVE acronym, it's important to remember in that way, because that's also the way in which we correct it. So we'll start in that order. So talk CAVUS first. CAVUS, by definition, is plantar flexion of the first ray. It is a forefoot pronation. It is incredibly important to, when you look at the baby's foot, the thing that makes the foot look the most normal on that first day is that CAVUS, because everything else looks so crazy. The only thing that makes it look somewhat normal is the fact that first ray is trying to get plantigrade, except that is deceptive, because that first ray is one of the major problems. The first ray is so plantar flexed that it has now dissociated itself from the rest of the foot. So by correcting that CAVUS first, by providing a supinating force with dorsiflexion slight eversion to that first ray, the base of the first metatarsal head, you are now restoring the forefoot, midfoot, hindfoot alignment. And what Ponsetti talked about is restoring the calcaneopedal block. So the calcaneopedal block is the entire foot minus the talus, because the talus is the center around which all foot correction occurs, not just in one plane, but all three planes. So by restoring the first ray up in that normal position, now you can externally rotate and abduct by pushing on that first ray with a fulcrum on the lateral talar head, and that will evert the talus, taking you out of varus into valgus. It will abduct the forefoot, taking you out of adductus. And then once you get externally rotated enough, you can then talk about treating the Aquinas. What made Ponsetti's treatment so revolutionary is he completely understood the foot and its anatomy and how things worked before he figured out how to correct everything. He had to go and understand the foot before he decided he was going to just say, I'm just going to push here and make the foot look straight. And so that kind of leads into a little bit of the history, if you guys are okay going off a little bit here for a couple seconds.
Let's do it.
Sure.
All right. So going all the way back to Hippocrates. Hippocrates described clubfoot, and he talked about serial bandages, and he understood that it was important to overcorrect the foot to prevent recurrence. And then, you know, between Hippocrates and the Dark Ages, all that information was lost. And then you got to fast forward to modern medicine, where they try to manipulate these feet again and not operate or not, you know, leave them as they were. And they just basically pushed on the foot. And the fulcrum they used most commonly was the calcaneocuboid joint. And they were trying to open up the foot through that joint. And it just, you know, we know the foot doesn't work that way now, but they didn't back then. And so because they had failed on these serial manipulations, people were operating on these things left and right. And it wasn't until Ponsetti really studied on this. And Ponsetti's history was, he was a surgeon born in Mallorca in Spain. And when Francisco Franco took over and started purging the intellectuals, he fled to Mexico. And in Mexico City, somehow someone from Iowa came down there and they had some conference, and they brought him back up to Iowa City and basically said, look, go wild, man. And so he started, you know, letting his mind carry him whatever he could get interested in. So he had tons of work on DDH, tons of work on feet. And it was through his work with stillborn feet where he really helped us understand how the foot moves. And so in the traditional Ponsetti method, he corrected what he called Kite's error. So Kite's error is putting your foot, your thumb on the calcaneus or the calcaneocuboid joint, where he said, no, that's the wrong place. If you touch the calcaneus at all, you're blocking the eversion. So you put your finger on the lateral head of the talus and you allow the calcaneus to evert underneath the talus to externally rotate and evert and even dorsiflex underneath there. So the anterior process of the calcaneus comes up into the sinus tarsi. And there's a couple really good videos of this. Ponsetti's model is available on a video through globalhelp.org. If you go to YouTube and look up globalhelp.org, And Clubfoot, there's a couple really fantastic videos, one of which is titled "Where to Put Your Fingers on a Clubfoot," which is a great video. But that kind of talks about the whole anatomy, correction, history of Clubfoot. Ponsetti, when he published his first paper on Clubfoot, was, I think, 19. I'm going to screw up these years, so I wrote them down at some point and I misplaced my card. But I think it was like 1963 was his first paper, and then 72 was his second paper. And it really wasn't until a couple decades after that where he really started to sway people's minds. And that was when his 34-year follow-up was published. And you want to talk about fate. If someone from New York City had grabbed Ponsetti, I don't know that we would have been where we are today, but people in Iowa City tend to stay around Iowa City, and we were able to get that long-term follow-up. So from 1996 to 2006, the percentage of POSNA surgeons who were operatively treating club feet as their primary treatment went from 72% in 96 to 12% in 2006. So to tell you how impressive a career Ponsetti had, he got an above the fold, full page above the fold obituary in the New York Times when he died.
Wow.
Man, that's wild.
So, you talk about, I don't know how many surgeons get that, much less orthopedic surgeons. Maybe DeBakey got it. I don't know.
That's yeah, I think it's good to know the history. Like once you start reading or hearing it, you kind of just want to hear more and more. And I feel we can probably talk about this for a long time. But no, I think that's it's crazy the impact that he had and how he kind of revolutionized the treatment of clubfoot. And I mean, it's just kind of amazing all the work he was able to do and what he was able to get published and the difference he was able to make.
Yeah, I mean he's just a really impressive guy, and his stuff for the hip is also equally as impressive. A lot of work on stillborn babies, so we thank those families for letting us learn on their children.
Yeah, and just to recap a little bit again about the anatomy, and so can we go again over what the CAVE is for?
Absolutely.
And what part of the foot, forefoot or hind foot, that we're referring to when we talk about it?
So, the four deformities are present on that day one. Your day one cast should assess, is there cavus? Not all of them have cavus, but is there cavus? And does that cavus need to be corrected before you start pushing on the foot? Because what that does is that is the forefoot that is completely off from the midfoot, which is then completely off from the hindfoot. And by restoring the position of the forefoot, by getting rid of the cavus, you've now got the forefoot and midfoot hooked back up together. So when you then put an eversion force on the first metatarsal, that pushes the entire now connected midfoot through the cuboid, which engages the calcaneus. And so that is the calcaneopedal block. So as you push on that forefoot, you are rotating the entire midfoot and hindfoot together. All those deformities correct together. And Ponsetti said you have to get at least 50 degrees of external rotation of the foot relative to the position of the knee in eversion before you talk about dorsiflexion. And he would talk about you could feel the anterior process of the calcaneus just below where your thumb is on the lateral talar head. And when you can feel that anterior process, you're ready to do the fourth deformity, which is the equinus. You may not address the equinus until you've corrected the other deformities. It's a huge mistake. There's a very, very specific exception to that rule, and that's for something called an atypical complex clubfoot, which has a very good paper written by Morquende, and I think Ponsetti was still alive when he wrote that paper.
So it seemed like the key, this is just kind of summing it up, and I know it's more complicated than this, but sounds like the key is getting the eversion through the first metatarsal initially. You need at least 50 degrees of external rotation, but by doing this, trying to get this plantar flex first metatarsal back everted, that is actually correcting the forefoot sound like we said forefoot, midfoot, and to some extent the hind foot as well.
Correct. So so when you push on the first ray externally, it pushes on the calcaneocuboid joint, which then everts the calcaneus, dorsiflexes the calcaneus, and rotates the calcaneus out of varus into valgus. There's an analogy in one of those global health videos that I really, really liked, where he said the calcaneus is like a ship cresting a wave. When a ship crests a wave, it has to pitch, yaw, and roll simultaneously to stay afloat. So does the calcaneus when it moves. You can't just try to move it in one direction. It happens in all three planes at the same time. So as you push on that foot externally, you're moving the calcaneus in three planes underneath the talus and through the subtalar joint.
Okay, I like that. And also, I kind of heard you say, and it just sounded like an excellent pimp question, probably a little bit more so towards fellow level, but you can't even consider, really fixing the equinus until you get about at least 50 degrees of external rotation before trying to work on dorsiflexion.
That's a test question too. So what happens if you do that is if you cut the Achilles and you forcibly push on the foot to try to get him out of equinus, the calcaneus isn't going to move because it's still stuck underneath the talus. And so where you're going to dorsiflex is through the midfoot. And that's where you get an overcorrected, horrible flat foot with clubfoot. It's bad news. I mean, I love treating clubfoot because you can take somebody that would otherwise have a lifelong debilitating problem, and before they're even in preschool, they're completely done with their treatment and look awesome. I mean, a handful of them go on to need some small surgery along the way, but nothing major. The major goal of the Ponseti treatment is, and I skipped this and I shouldn't have skipped this, is a painless, flexible plantigrade foot. It's not a foot designed to win a beauty contest. It's going to look a little bit different than a normal foot. The most obvious way a foot looks different, if you look at your own foot and you look at your extensor digitorum brevis, and it has that nice convexity to it. Every clubfoot has a very underdeveloped extensor digitorum brevis, along with every other muscle in their leg, and it looks a little different. And even if you have a perfectly symmetric and length foot and there's no real shoe size difference, you can always tell which one is a clubfoot by looking at the EDD. So the goal of Ponseti is to stay out of the joints. And that's why his treatment is so important, because once you operate on a clubfoot and you go through a joint, that joint is never the same again.
So we can move, we pretty much did just talk about the Ponseti method for the most part, but
yeah.
What about if you do nothing at all? Say this.
But before I get to that, there's a couple things I didn't talk about which have to be talked about. I'm bad for not mentioning it. It's a long leg cast. It's always, always, always a long leg cast. You cannot control the rotation through a short leg cast. There still are some jokers out there trying to do it that way, and you can't do it. And I know because I see their patients long term, and you can't correct it that way. So that's first and foremost most important. Now, if you don't correct this, I don't know if you guys have ever traveled internationally, but you will see people out there who have uncorrected club feet, but they're not young people, because through Ponseti's international organization, almost every country in the world has people treating club feet now. But when I traveled to the Dominican Republic in the early 2000s, I used to pass a guy every day who would panhandle and had a unilateral club foot. And I got up the courage one day to go talk to him and say, "Hey man, I'm working at a charity hospital. We can fix your foot." He said, "I was never educated. My family gave up on me. This is the only way I can make money is by panhandling." And so, that guy was literally walking on the dorsum of his foot, right? Because that's how it's shaped like a club. Look at that. The people listening can't see it, but on the screen, if you're watching on YouTube, you can see the infant model. That first picture, you'd be walking on the lateral border of your calcaneus and your talus. And so your body, what's really weird is you develop a calcaneal fat pad there.
Yeah.
And so, you can't wear shoes. It's a lifelong problem.
Yeah. I mean, of course, that will be a big issue, right? I mean, you'll probably have where your skin calluses there in that area, like you say, the problems with shoe wear. I would imagine I don't know. Is there any increase in like infections or anything like that? I guess skin breakdown. That you,
You know, not that I know of. It is possible to fix way later in life with like a triple arthrodesis, but I will tell you that so a few PD pods who like to travel overseas. Dave Spiegel from CHOP is one of the ones who's published the most on um, beginning the Ponseti treatment in the walking age child, and he has really amazing results treating kids between ages 1 through 6. And I think something like only like 14 or 15% of those kids needed operative treatment. So even in an older kid, you can start Ponseti treatment. I mean, it just works. And that's actually how, when you get a relapse, your first treatment isn't the knife. Your first treatment is casting again, trying to restore some of that treatment back by casting it out.
yeah. So I guess
So there
that's
you go.
yeah. Yeah, I was trying to
Getting all
catch
the
up with you
points.
there. He did. He really did. We went through everything in a very efficient manner, I think.
Actually, let's touch on bracing. When
Oh,
do you
yes.
use
So
abduction bracing, or when,
yes.
or how
So
long?
you have to. So here's the thing. It's kind of like, I don't know if you guys had dental braces. I did growing up, and I never wore my retainer. And shockingly, my teeth kind of went sort of back to where they were before
Yeah.
we started.
Yep. Same
So
here.
that's the
Yep. Same
analogy
thing.
I give. That's the analogy I give to every parent, which is, look, the orthodontist can put you in braces, but if you don't wear your retainer, your teeth are going back. And it's the same thing for the feet. So my first visit with these families, whether it's the prenatal visit or it's the first time I meet them postnatally, I go through the entire thing where I say, my treatment phase is somewhere between 3 and 8 casts. Your child may or may not need an Achilles tenotomy, but your child will definitely be braced. Now, the duration of bracing is debated very intensely. Ponsetti, when he first described it, said, oh, up to 2 years you can brace. Had about like half his patients relapse. So then he extended it to between 5 and 6 years. I will tell you that it's the true Ponsetti acolytes stick to 5 years. And when I say acolytes, I mean like they are disciples. They
Yeah.
are out there like hardcore preaching about the true Ponsetti way. If you talk to a lot of people out there who are treating clubfoot, it varies between 3 to 5 years for the most part. And so the thoughts of bracing are that you must brace until at least their third birthday. And the reason is because that child is still rapidly growing and the foot's going to try to go back to its original position. The forces pulling it back into the original position are the original tightness of the muscles that cause it in the first place. But you can also run into some issues with the tibialis anterior tendon, where if the tibialis anterior tendon is attached slightly more proximal or slightly more plantarly than it should have been on the dorsum of the first metatarsal and the medial cuneiform, and it's a little more on the medial surface there, you'll get what's called dynamic supination. So when you enter swing phase of gait and the foot needs to dorsiflex so the toes can clear the ground, you have more of a varus and supination pull than you would otherwise have. And over time, that can cause you to get a more static deformity of recurrence of your adductus and recurrence of your varus. And so that is the most that and true equinus are the deformities that you'll see come back. What is clear is that you should treat recurrent equinus. What isn't clear right now is what is the specific trigger to do a tibialis anterior tendon transfer. Is it isolated? Like if you identify in a 4-year-old dynamic supination, should you take that child to the operating room? We don't know yet. Or should you wait to see if that child does develop dynamic supination that results in a static deformity? It's very debatable. I'm pretty aggressive on that because I would rather not have to tell a family you got to brace a kid for 6 years if I can just treat the dynamic supination now. Because I don't know if you guys have kids, but I can tell you by their third birthday, a lot of these parents are done with bracing.
Yeah.
Yeah. But that's the importance of bracing, and it is. This will be on your test questions, where it is the most important factor for recurrence is failure to comply with the bracing protocol. And I stress that with the families. I don't blame my families for anything. I'm a I'm a very, it's all on me, kind of the buck stops here kind of surgeon, but I let them know, man, if you guys stop bracing, you're going to guarantee your kid a relapse.
Yeah. And you say you braced to the age of 3. And
Yeah.
I think you did a great job describing the dynamic supination. I read that many times in the past, and I understood it, but I didn't really understand it per se.
Yeah.
But your explanation was great as far as
Once you see it, you'll never,
yeah.
you'll never, like, that's why it's so important. Like you said before, when you go to examine a baby, you get a sense of how you're supposed to do it. It's the same thing. A lot of this is, I will tell you that my residency, I was trying to get in the OR as much as I could, right? But you really do learn a lot in the clinic if you pay enough attention. And I really tried to avoid a lot of clinic as a resident. And as a fellow, I started to realize, oh man, I'm going to be seeing these people in the office way more than I'm going to be operating on them. So I better learn how to be an office physician too.
Yeah.
And so once you see these kind of things, you won't forget it.
And one thing I didn't mean to ask is regarding your Achilles tenotomy after you've done your
Yeah.
Ponsetti and you're ready to fix the equinus. I've heard some reports of some people doing it in the office under local anesthesia versus going to OR. Do you have any preference?
My preference is always in the office. I will do them in the office up till 6 months of age. So for a couple reasons. One is convenience. Another is cost. I did my first few in the operating room to make sure I knew what I was doing. And then once I felt really comfortable doing them, I've done them all in the office ever since. Hundreds probably at this point.
Yeah.
The way I do it is you put a little LMX cream or some kind of, local cream on the area. And then I'll come in and inject 1 cc of a plain lidocaine superficially, and then get half a cc, and then deep in the tendon sheath gets another half cc. And then I use a 3 millimeter beaver blade, a little cataract beaver blade, and I go just medial to the Achilles tendon and just cut it right there in a quick little 3 millimeter incision. Hold pressure for 15-20 seconds. There's no more bleeding, and you're done. A couple nice things that's nice about doing in the office is the babies don't cry when you actually do the procedure. They cry when you dorsiflex the foot, when you are stretching all those posterior structures out for the first time.
Right.
What's nice about that crying is when they Valsalva, the foot turns the most scary shade of white you've ever seen in your entire life when you first dorsiflex that foot. And you think, oh my God, what have I done? And that's that like 2-vessel foot that goes into spasm for being in that position. And you got to wait for it to recover. Now, when they Valsalva and cry, that blood flow comes rushing right back in. When they're under anesthesia, you got to wait till they wake up to see that blood flow come back. And that's a long 10 minutes. I'll tell you, it's a long 10 minutes.
Yeah,
I used to get the French
sweating.
fry lights out. Oh yeah. My first couple, I had like the French fry lights, everything out. But so another good thing is I will tell you that Tony Herring in Texas tells a good story. When he was a brand new staff, he had a baby lose their ET tube and their IV at the same time. And he's sitting there holding the 15 blade thinking, how in the heck am I going to do a trach on this little baby? Thankfully, the baby was fine, but he's got a nice little saying, which is they may cry in the clinic, but they don't die in the clinic.
There it is.
There it is.
There it is. So, we have a specialist on our podcast right now on Clubfoot. And just before we completely wrap it up, what are the top 5 things you hope that residents, medical students, and anyone else dealing with these this pathology, what are you hoping that they can get from this talk?
Even fellows.
Yeah. So the first and foremost is a child who has been successfully treated with the Ponsetti clubfoot treatment should expect to have a normal functioning foot. There's no limitations to them. So Troy Aikman had clubfoot. Mia Hamm had clubfoot. There's been, amazing, achieving, athletic people who've had club feet. And if you treat them the right way, sky's the limit. It's not a limiting diagnosis. So it's really something that will allow, when you treat it the right way, it really is like it never happened. Yeah, someone might need to wear like one shoe that's a 9, the other shoe might be a 10. Well, guess what? Zappos now does that for you. You can go buy different size pair of shoes. But that's it. That's the most important thing. The other stuff, you got to remember your mnemonic. You got to remember cave. Understand that if you don't have Aquinas, it may not be clubfoot. Understand that if you go watch the video of the Ponseti model from globalhelp.org on YouTube, it will really help you understand. You'll watch that anterior process of the talus. It's almost like if you look at a map of Pangea before all the continents split up, you can see where Africa used to fit into South America and all those things, right?
Right.
If you look at how that anterior process of the talus fits in the sinus tarsi, you're like, oh yeah, I mean, that makes total sense. It's like it was designed to go there. Yeah. It's like a puzzle piece. And I mean, you probably remember back to your first day in anatomy lab, and you go back and you look at these organs and you're like, man, this design is really amazing. And when you go back and you learn all those horribly boring things, and you got to study for your OITEs about cartilage and how like cartilage on cartilage is like 100 times smoother than ice on ice and all those amazing things. The design there is really amazing. If you go and watch those videos, you really understand the whole rotation of the calcaneopedal block. And it doesn't just apply to club foot. If you look at your own foot right now and you swing your forefoot up into supination and then out into eversion and watch what your calcaneus does while you do all that, you'll see how it all works together. I will tell you that I used to think the foot was just a dumb hand. And then I really got to appreciate how the foot works and appreciate what it takes to correct these feet. And I gained a lot more appreciation for the foot.
Dr. Gantsoudes, I really appreciate you. We really appreciate you coming on and talking about Clubfoot. I think this was a great talk. I think we definitely hit all the high
pleasure,
points.
Guys.
I think, again, thank you so much. And before you go, we always ask our guests, if there's any way that the listeners can reach out to you, or that's email or social media or follow you or anything that you would like to share. Don't have to, but if you would like to.
I mean, the most accessible way to reach me is probably Twitter, which is unfortunate for my family. That's easier than email. I'm at peds_ortho, and my email, if you need to reach me, I'm not all that great at checking email, to be honest with you, but it's just gantsoudesmd@gmail.com. But I do check my Twitter, but I check my email, which is bad.
Well, that's how it goes sometimes. Yeah. Dr. Gantsoudes, we really, again, thanks so much for being a guest.
Hey guys, my pleasure. Thanks for having me.